Good morning. It's July 3rd. I'm Mary McDevitt, retired physician, and I've been asked to record this presentation for the Healthcare for All group in Napa, California. Um, it's titled Why We Need a Single Payer Healthcare. So I hope to go through some of the reasons and also update you on some of the interesting recent happenings regarding healthcare, especially in California. Are we entitled to health care? I would claim that we are. It is stated not directly, but in the Constitution that says that we should promote the general welfare, and certainly the health of our citizens would come under that. If you don't like that reason, then you can go to the Universal Declaration of Human Rights, which was passed in 1948, which states specifically everyone has the right to a standard of living adequate for the health and well-being of himself and of his family, including food, clothing, housing, and medical care. Now, I would contend that our healthcare system has failed, and it does not promote the general welfare. We have 30 million Americans uninsured, even more that are underinsured. Our system delivers poor healthcare outcomes. It delivers care at a very high cost, and we obviously spend more and get less. And medical bills now account for a third of all bankruptcies. We have high waste in the system. We have high overhead with our for-profit insurance companies, overhead going up to 20%, whereas our Medicare program has an overhead of 2 to 3%. We all know that there is exorbitant charges for medications, and this system is driven by for-profit insurance companies, pharmaceutical companies, and recently I have added hospital chains. And this system is unsustainable. We have to change. We have to do something better. For right now, we have no real system and we have no control. Waste has been documented. This last time was from JAMA in 2019, which estimated that we spend $935 billion per year in waste. You can see there the top item is administrative complexity with dealing with all these insurance companies and other as well. Is healthcare subject to the market? You'll hear people say, oh, well, the market will take care of the prices and bring down the cost. So here's a really definition of what a true market is. Consumers know what they're buying. They face the full cost. They have time to deliberate and make a decision. They have many options where and from whom to buy. And they may choose not to purchase a service or an item. And a market exists when you have many buyers and many sellers. Well, we do have many buyers and many sellers, but we certainly don't meet some of the other criteria. And our healthcare really comes under this concept of inelastic demand. And what that means is it doesn't change no matter what the price is. When you have a heart attack, you need healthcare, and you are not going to be able to shop for the cheapest hospital to deliver care to you. So our present healthcare system is a failed business. It has poor outcomes, it has high overhead, and it has very poor customer satisfaction. In contrast, our healthcare insurance is very profitable business. United Health Group, which provides my supplemental insurance, its profits for last year accounted to $15.4 billion. That is not a mistake. It is $1 billion profit. Cigna had 8.6, Kaiser, as you can see there, 6.4. Now, Kaiser is supposedly a nonprofit, and its insurance and its buildings are under nonprofit, but the doctor group is for-profit, Permanente, yet they're under a nonprofit umbrella. So we'll call theirs net income was 6.4 billion, and poor Humana only made 4.6 billion. Now, economic rules. I got this from Dr. Rosenthal's book, American Sickness, and I think it raises some good points. She claims that in our present medical system, more treatment is better. You default to the most expensive option. A lifetime of treatment is better than a cure. Amenities and marketing matter more than good care. We certainly see that in some of the new hospitals with their extravagant marble lobbies. As technology ages, prices are supposed to fall, but in healthcare they rise. And there is no free choice. Patients are stuck. They're stuck buying American. They're stuck buying what their insurance will cover. More competitors in healthcare doesn't mean better prices. It can drive prices up, not down. And the economies of scale really don't translate in healthcare to lower prices. With the market power, especially for hospital chains, they can simply demand higher um, pay for their services. And there's no fixed price for a procedure or a test, and the uninsured pay the highest price of all. There's no standards for billing. There's money to be made in billing for anything and everything, and prices will rise to whatever the market will bear. Now, employment-based healthcare, half of Americans get their healthcare through their employer. The number in that category is even more than putting Medicare and Medicaid together. The average premium for a family of four is a 21,000. Usually the employer pays on average 15, the employee pays 6,000. These are averages. The deductible in these policies for 2020, the average was 1664, but some deductibles go up to $6,000 or even $8,000 a year. We're all familiar with the gig economy. We recently had some legislation suggested where they should be employees. That the legislation did not pass. So they are contractors. And as of 2019, there were 47 million workers in the gig economy. What that means is they do not get benefits. They do not get health insurance. And then our most important recent factor is the COVID pandemic, where people lost their jobs and naturally lost any health insurance they had as well. Now, employer-based health insurance, it's your employer who decides how many plans will be offered. Sometimes they shop for new plans, cheaper plans every year, which they can. Each plan that they offer may have different networks of doctors and hospitals. And some employers send you to the ACA exchanges for you to select a plan. And on the exchanges, sometimes there's up to 60 plans. The state of California, CalPERS, offers 15 insurance providers to the state employees. And as of 2019, the state of California spent $9.3 billion to provide healthcare. Now, this graph I think is important. It's from the Kaiser Family Foundation. And remember, I told you the deductibles can go up to $8,000. I think the important thing here is if you look over the last 10 years, the increase in workers' earnings, which is 27%, how that corresponds and how those workers would be able to pay deductibles that have increased over 100%. Now, this is a survey just found this year, was done this year. It was done of executives of large companies that had at least 5,000 employees. 300 were surveyed. And this is the results. 90% of these executives felt that the cost of health benefits will become unsustainable in the next 5 or so years. And 85% said that they expect that the government will be required to intervene to provide coverage and contain costs. Now, we know that employers do foot most of the nation's healthcare bill. And if we could get them on our side, they would be a powerful counterweight to the insurance lobbyist. And then for your business, every dollar that you have to spend for healthcare is a dollar less that you can give to your employees or invest in your company. And because of these big healthcare costs, American businesses are less competitive in global markets. Now this, I have done some research on Medicare Advantage programs. And this concept of people should pay a copay really originated back with in 1970s with the Rand Corporation in Southern California. And they did a study and found that a small copay encouraged patients to use fewer services without leading to worse health outcomes. Now, back in the 70s, they were talking about a copay of $25. Uh, Recent study, I don't think it's been fully published yet, but it is this year. It's a study done by Berkeley and Harvard, and they found that $10 can be a matter of life and death, which would be an increase in the price of a drug led to significant decrease in patients getting that medication. But they followed on and found that it was associated with a 33% increase in mortality. And the drugs that were not obtained were drugs that were related to the greatest health risk and diseases like heart disease, hypertension, asthma, and diabetes. So these people were not taking medications that they really needed to maintain their health. Now, the government could limit cost sharing or eliminated it. If we're eliminated, then we get into Medicare for all. But Medicare did recognize this problem with the Advantage programs. And for this year, they put a limit on out-of-pocket expenses in Advantage programs at $7,550. Now, all these different programs vary in what they count as out-of-pocket expenses. So you really have to study your program or the insurance plan that you're considering going into. Now, these are some state figures. I already mentioned 9.3, I think 9.4 on the other slide, that the state paid in 2019 for employees, family, and retirees. I did a study here in the town of Sonoma. Now, we only have a population of 10,000. And our expenses were very low, 70,000 a year, but we do not have our own sheriff's department, fire department. We contract that out. And as in the contract, we don't have to pay for healthcare for those first responders for our town. But if you look at Sonoma County, and I got this through Susan Gorin's office, last year they paid $84 million for healthcare benefits for employees of the county. Now, this next quote is a letter that was sent to every member of Congress in 2019 and to, as I had note there, the people of the United States, which states the following, and it's just half a page letter. It says, public financing for health is not a matter of raising new money for healthcare, but of reducing total healthcare outlays and distributing payments more equitably and efficiently. Implementing a unified single-payer system would reduce administrative costs and eliminate individuals' and employers' insurance premiums and out-of-pocket costs. If combined with public control of drug prices and a dramatically simplified global budgeting system, a sensible Medicare financing system would reduce healthcare costs while guaranteeing access to comprehensive care and financial security to all. This letter that was sent in 2019 was signed by 219 economists working here at university and other places in the United States. Now, I wanted to talk a little bit about hospital charges because there's a lot in the news about them recently. And the hospital document that each hospital has, it's different for each hospital, is called the Charge Master, where everything is priced. And the most famous thing a couple of years ago on that Charge Master was an aspirin would cost you $5, probably $10 now. So when an insurance plan goes to the hospital, the finance person takes out the charge master and they negotiate a discount from those charges. Could be 10%, 20%, whatever. Now, if you come as an insurance program with a large volume of people that can use the hospital, you can negotiate a lower discount or a higher discount from the charges But you can also request this most favored insurer agreement, which would require the hospital to charge rival insurance plans up to 40% more. And a hospital, most of them, will have at least 10 to 13 different prices for the same procedure if they have 10 to 15 insurance plans that they negotiate and contract with. Now, our former president put out a rule that hospitals must make their negotiated prices public starting in January 2021. And the Wall Street Journal had an article in February which gave a report on Sutter Health and their range of prices for the same procedure. And you can see the range for C-sections and major joint replacements. Now, the lower number is usually always what Medicaid would pay, and the highest ones are private insurance. Now, this is a surprise bill in my own family that I wanted to review. This was a 50-some-year-old relative who was a construction inspector, member of the Operators Engineers Union. He had insurance through them, through Blue Cross, and he had to have a knee replacement. He lives in San Mateo, so he went to Mills Peninsula Hospital. It was in network for his insurance company. And the total bill for that procedure was $81,000. The Blue Cross contract was $61,831, but the Blue Cross had put a cap on what they would pay of $34,000. So the patient received a bill for $27,000+. Now, I researched this because I'd never heard of reference price, and it turns out that CalPERS several years ago, that pays for state employees and retirees all over the state, were getting hospital bills for knee replacements that ran from $10,000 to $125,000. That should be an extra zero there, sorry. So they called in some researchers and they asked them the question, how much should a high quality knee replacement cost in California? Answer was $30,000, and this was the reference price. During the next 2 years, CalPERS had saved $2.8 million on joint replacement surgeries after they instituted this reference price. Now, if you want, you can look this up. It's in Elizabeth Rosenthal's book, and I would suggest that you get this. It's a fascinating book about an American sickness. And a more recent is Medicare for a Citizen's Guide by Dr. El Said, and I'd recommend that too. Now, I have here, do we have too much choice? Well, in 2019, for Medicare enrollees, there were 10 Medicare Advantage programs in our zip code here. They all limit doctor and hospital choice, probably different limits. And there were 28 Part D drug plans. A report has come out that said in the first year, 88% of enrollees usually choose needlessly costly plans for their drug plans. Now, there are 28 Medicare supplemental plans. These are the plans that you get if you have traditional Medicare, then you get supplemental. There were 4 insurance companies, each had 7 different plans offered, and they all had different copays, different deductibles, and different out-of-pocket expenses. Now, the Affordable Care Act, Obamacare, as you know, is managed through an exchange. On average, they have 19 plans, and all of those plans are supplied by private for-profit insurance companies. Now, I put these slides together because I got tired of seeing all these ads on TV on the evening telling you about Medicare Advantage plans and essentially almost saying that they are free. They are not free. And so I wanted to review some of the data regarding these. And for the state of California in 2019, there were 425 Medicare Advantage plans offered, all by private insurance companies or other, well, I would consider Kaiser private insurance as well. In Sonoma, Medicare pays the Advantage program a little over $1,000 a month to take care of you. If you have comorbidities, they will get what's called additional risk payments. There's no deductibles in these Advantage programs as they advertise. They do advertise that, but you get copays, copays, copays. In 2021, as I mentioned before, the Advantage out-of-pocket limit mandated by Medicare is $7,550. Now, Medicare does audits of these Advantage programs. They usually come in and they'll review 200 charts. What they have found that these Advantage programs are notorious for overbilling and to the tune of $10 billion a year. And the way they do it, they exaggerate how sick their members are. Now they call it billing errors, but it's really upcoding. And the example I gave, if there is a diagnosis of arthritis, if it is coded as degenerative arthritis, there's a lot less risk payment for that patient versus if it was rheumatoid arthritis, which is a more serious disease requiring sometimes very expensive medications. So 2 years ago, Medicare introduced a new enhanced audit procedure. And what they now have implemented is called the extrapolate error rate. So if they do a random sample of 200 patients and they find upcoding, or what the insurance plan would call billing errors, they are going to extrapolate that error to the plan's full membership. Since 2019, they have done 90 enhanced audits, which have brought in $650 million, which they determined was overpayment to these Advantage programs. Now, since I'm doing this for a Napa group, I did look at the plans available in Napa. Their Advantage is $4 more than if you're an Advantage person that lives in Sonoma. So that's what you would be paid, or what would be paid by Medicare to your Advantage program in Napa. Now, you still pay your Part B premium, which for 2021 is $148.50 a month. Now, most plans do include dental, vision, and hearing. And I have listed there a little chart that shows the number of plans in Sonoma. There's 11, 8 in Napa, supplemental plans, the same in each, and Part D plans, the same number in each. So in these Advantage plans, you have copays for almost everything. You have a copay for a hospital day, an office visit, an outpatient service, specialist visit, and medications. And I just wrote down here the process that they use for medications. As you can see, there's 5 levels, depending what medication you're on and what tier it falls in. Your copay can be anywhere from $10 copay to 33% of whatever the cost of that specialty drug is. And these are the ones that are very expensive in tier 5. Now, Medicare enrollees, even if you're an Advantage program or you have just traditional Medicare, or you have traditional Medicare with supplemental insurance, people are still not able to pay their bills. And this is a study that just came out, was reported by the Kaiser Family Foundation. And they found that 42% of Medicare enrollees are in Advantage programs. The reason for this is the intense advertising that they're doing. Every night around news time, they are advertising their programs. And also there was a change in the law that allows them to create new supplemental benefits, such as gym membership. Gym membership is really focused on seniors that are well enough to go to the gym. If you have multiple medical problems, you're not be going to a gym, even if it's free. So essentially, it's a form of advertising to give that free benefit. Now, if this study that just was reported, if you look at all Medicare enrollees, 17% of this survey of Medicare enrollees said that they could not pay their healthcare bills. The Advantage group in that population, their response was 19% of them couldn't, as opposed to traditional Medicare enrollees who reported 15% could not pay their bills. If you break down a Medicare, traditional Medicare, some people had no supplemental, and they reported 30% of them could not pay their bills. If they had supplemental, 12% said they still could not pay their bills. So this is being followed by this Medicare watchdog group. If you're interested, you could check it out. It's medicarerights.org. And the bottom there, I have where this report came from. Now, I consider corruption of a hospital system, and I'm giving as an example Sutter Health, which I was employed by when I was a medical director at Marin General Hospital. Now, they did a lot of good things. While I was there, they built Nevada Community Hospital. After I left, they had finished building California Pacific in San Francisco. And they had also built a nice little hospital up in Amador County, where I have a place. Unfortunately, they got into a lot of trouble. And in 2019, they settled a kickback lawsuit, $46 million. They were paying surgical assistance for their cardiac surgeons, and surgeons were also billing Medicare for that. They also settled an antitrust lawsuit. Remember, I told you how they could, certain ones could say, if this healthcare plan is preferred, then you have to charge more to your other contracted health plans. So that was considered antitrust, and they had to pay the state of California $575 million. And a federal antitrust suit is still pending for Sutter. Now, I did mention our former president said hospitals have to make their prices available. And this is the breakdown for Sutter hip and knee replacement. Medicaid, as I told you, is usually the cheapest. Medicare is mid-range, and commercial insurance goes anywhere from there. As you can see, the lowest and the highest cost is what my relative was charged at a Sutter facility. Now, it's interesting, with all the money that they bring in, the Sutter Health still did receive COVID relief payments to the tune of $812 million, and also asked Medicare for advanced payments, which they received, I'm told, of $999 million. Another effect of our failed healthcare system. And this is a worry to me because physicians, independent practice physicians, are leaving their independent practice. And this was a survey done by Physician Advocacy Institute in June of this year. It was reported, but they looked at doctors that were leaving private independent practice between January of 2019 and 2021. So it's a 2-year period. And the second year of that, of course, was COVID lockdown time. And they found that almost 30,000 physicians left independent practice to join corporate entities. And I just give one example there would be United Healthcare, which developed Optum, which in addition to other things is buying up physician practices. And almost 19,000 physicians left independent practice to become hospital or health system employees. Now, why did they do this? Well, reason given by most physicians is they just are tired of paying the high overhead to maintain a practice where maybe they are dealing with 10 or 12 different insurance programs with different requirements, different networks. They have to ask for pre-approval when they want to order certain tests. And they are also, my own experience with friends of mine, we're told that they're taking too long to see patients, and that they are being managed or overseen by non-physician administrators. And so even now, I know of one physician in a practice that is managed by a healthcare system who is ready to leave medicine. Now, also to me, this is worrisome because we don't have enough doctors in California. We do have a shortage. And if some of these physicians are ready to give up medical practice, we're going to have a crisis in the near future. For the whole United States, as you see in the bottom there, 50% of all US doctors are now employed by hospitals or health system, and 20% are employed by corporate entities, such as United Healthcare and their Optum program. So only 30% of our doctors today are in individual or small group private practice. I think that's a problem. Now, you might have heard of Medicare for All. I'm not going to spend a lot of time on this, just to tell you it was reintroduced by Pramila Jayapal on March 17th. You can see there what it covers. There's no deductibles, no copays, no out-of-network to be implemented over 2 years. And the budgeting for the hospitals will be an operating global budget and capital budgets. And I think in summary, Medicare for All is defined as a single public nonprofit health insurance. And for those that said it's government healthcare, it is not government healthcare. It is government-run health insurance. Health services would continue to be provided by independent physicians and hospitals. And if this is adopted, it will return financial security to Americans. Now, the Congressional Budget Office last year, they have to evaluate all legislation as far as its cost. They're supposed to be nonpartisan. And this was their conclusion, that replacing our current system with a single payer would ensure every American while reducing overall health spending in the country. A single payer system would save 42 billion to 743 billion. I've noticed when I look at their reports, they always give their numbers based over a 10-year period. So that's where the 743 billion come from. Now, CalCare is the bill that was introduced earlier this year. It is a single payer system for the state of California. And one of the questions that has come up, well, didn't Vermont try and do this? And they couldn't do it. So how do you think California can do it? Well, in Vermont, the governor ran on it in 2010. He was elected. And he tried to implement it for the period 2011 to 2014 when they gave up. And one of the main problems they had was to make a state system successful, you need to get waivers to get all the federal dollars to come into your state trust or whatever you want to call it to provide healthcare. Medicare has federal dollars in it. Medi-Cal has federal dollars. The CHIP program has federal dollars in it. And the Obamacare insurance on the exchanges are supported by federal dollars that subsidize people who can't afford to pay for that insurance. So the Obamacare law that was passed in 2010 had stated that you can't even ask for any waivers to do anything different with this program until 2017. So the governor and some of his colleagues took a trip to Washington and they came away empty-handed. They could not get any federal money. So since they didn't have the federal dollars, they would have to have a higher income tax and higher tax on employers. And this was a no-go. So that's why they had to give it up. Okay, in California, we have the legislation has been introduced. It's on hold right now, but it's coming back in January. And Governor Newsom called together the Healthy California for All Commission to look at the possibility of a single payer system in California. They are working right now, and the report should be ready in January or February. In May of this year, we were told that the governor has requested waivers from the Biden administration. They are called transformation cost waivers and universal coverage waivers to try and get all those federal dollars to come into the CalCare Trust Fund. Now, besides the waivers, there would have to be some changes in California law related to the Knox-Keene Act, which regulates HMOs, and also Prop 98, passed in 1988, which says 40% of new taxes has to go for education. Now, also, I wanted just to notice Representative Khanna has introduced a bill that would support state-based universal health care, and that is presently being considered in Congress. Now, this is a lot of information, but I think the most important thing, if you think that you can support a single payer system either nationally or for the state of California, I think it's more likely the state of California. Here's a couple ways to get involved. First is to contact the California Nurses Association. They wrote the bill AB 14, and they are lining up a lot of activities in support of that between now and the end of the year. And I also follow what's going on with CalCare. And if you would like to get on my mailing list, just please send your email address and your name to me at mcdevitt152@comcast.net. So that is the presentation. Thanks for your interest. If you have any questions or comments, please email me. Thank you very much.